Good morning. My name is Martha Harrelson, and I want to thank you all for allowing me to be here. I truly do. It has been an awesome experience. My observation hours here in the women's group, incredible. I can't thank you enough for this experience. And Shantae, you're an incredible counselor. I've loved every minute of it. And Linda, thank you for allowing me to come here from the get-go. When I first called her up, she was like, "You want to do what?" I said, "I really want to come there and do my observation hours." Now, let me give you some background. I'm a neonatal nurse at Forsyth Medical Center. I've been in the nursery for 32 years. Been taking care of sick and premature babies for a long, long time. In the past, I'd say 5 years, we've seen an increased number of babies that are born to mothers on methadone. And there's a lot of miscommunication. There's a lot of uneducation about it because we just haven't really connected. We've never communicated. So this semester, well, let me back up 2 years. I became a clinical shift manager, and I had an associate degree, nursing degree. So I had to go back to school to get a bachelor's degree, and that's why I'm here. Gardner-Webb University is where I'm getting my bachelor's degree, and so a part of this education process is a public health practicum. So I had to choose a location to do observation hours, a teaching project, and a brochure. So because of where I work and what I do, was my first choice. And so when I contacted Linda, she made it happen for me, and I really appreciate that, and thanks for being here.
We appreciate you.
So, neonatal abstinence syndrome. That's where I'm starting, and that's the education that I would like for us to know, and that the communication and the connections that you'll make will hopefully make delivery of your baby and the stay in the hospital a lot easier. The syndrome itself is a group of problems that happens when a baby is born. They've been inside of mama, exposed to whatever she's getting, and so when they're delivered and that cord is cut, that baby is no longer getting that substance, and they withdraw. So it's a complicated myriad of problems, and we see it a lot. Out with methadone because that's mainly where I came to with this education process. So methadone has been used for the treatment of opiate-addicted pregnant women since the late 1960s, and I had no idea that it had been going on that long. But the benefits of methadone treatment, as all of you can attest to, is tremendous because it does keep you off the streets. It does improve prenatal care and the outcome of the babies. Now, they still have the syndrome, the withdrawal syndrome, but the outcome is so much better, and it gives us a place to start when we start treating their symptoms. Subutex, somebody in the group asked me about Suboxone or Subutex not long ago, and so I added this slide in because there's just not a lot of information on it. Buprenorphine is a partial mu-opioid antagonist, and it is used as an alternative for opioid dependence, but it's not been exclusively studied or extensively studied in pregnancy. A small study found that there was no real difference in the percent of babies requiring treatment for NAS, but the length of stay and the length of treatment was less with the Subutex group. Keep in mind that whatever you take in your body goes into the baby. So what causes neonatal abstinence syndrome? The drugs that pass through the placenta to the baby during pregnancy. The baby becomes addicted along with the mom, and at birth the baby is still dependent on the drug. Now this is any drug. Now I'm not talking about just methadone or Subutex. I'm talking about anything that you take in that causes an addiction. The baby is getting it. So because the baby is no longer getting the drug after birth, the symptoms of withdrawal will occur. The American Academy of Pediatrics reports that 55 to 94% of babies that are exposed to opioids and the derivatives of it during pregnancy will develop neonatal abstinence syndrome. So it's a 50-50 chance at least, up to 94% chance. Babies that are experiencing withdrawal have real pain. They are like this a lot of the day, and I'm going to give you some hints of what we can do to keep this from happening. So the symptoms of NAS can occur within 2 hours of birth, up to 14 days after delivery. Most babies within 72 hours will start showing symptoms. Some symptoms can last 4 to 6 months, some even longer, depending on what drugs are ingested. The benzodiazepines and barbiturates have a longer half-life, so the symptoms may not develop for 2 to 4 weeks because that baby's still got some in the system. So when it's finally out of the system, it could be 2 weeks. Moms who use multiple substances, the babies will have more intense symptoms of neonatal abstinence. So if you're on methadone and then you're taking something else besides that, or if you're using polysubstance, the babies will have more intense withdrawal. So the symptoms, the neurological symptoms, the most, I guess, I want to say annoying, and I don't mean that in a bad way, but the most annoying symptom of NAS is the excessive high-pitched cry. And nobody wants to hear a baby cry because we all want them to be all cuddled and sweet and happy. But that particular symptom is one of the worst. They're irritable. They have increased muscle tone. Their arms and legs are kind of rigid. They have tremors. They shake a lot. And they could possibly even have seizures. Now, the GI symptoms, I'm not sure why the excessive sucking and rooting came into that, but I think they are hungry. And so they suck on their fist and they root, but they don't feed well. They have diarrhea, and it's usually watery stools, and a lot of times they'll be vomiting. Once they get it in, they're spitting it right back out. So feeding's a real issue. The metabolic symptoms, they sweat. I mean, if any of you have ever experienced withdrawal, you know that sweating is one of the biggest things, and babies will sweat. They'll be just sopping wet, especially under their little arms, and you have to really make sure that you don't bundle them too tight, that they don't get too overheated. They have nasal stuffiness. They sneeze. If the sneezing is like 3 times in a row consecutively, that's considered one of the points that we'll score on. And they also will have fever. Other things, obviously, if they're not tolerating feeds, they're not feeding well, they're having diarrhea, they're going to have poor weight gain. Plus, this excitability, the tremors, that burns up more calories, and so they're not going to grow as good. And we'll talk about things we can do for that. They have poor organization of sleep patterns. Babies should eat and sleep, but they won't. There's a lot of excoriation of the skin due to excessive movement. They're doing this rooting, and they're wearing their faces out. A lot of times their bottoms will be excoriated or raw because of the diarrhea. And there's the constant movement, maybe their elbows. A lot of times will just have raw skin. Ones to kind of keep them contained so they're not tremoring and excitable. Skin-to-skin holding. We love it when mama's kangaroo. Open up their gown, put the baby diaper-clad baby to mama's skin, and quiet. Nice, quiet, low-light atmosphere. A pacifier will help with that excessive sucking need. Frequent diaper changes, obviously because of the diarrhea. We don't want that sitting on their bottom, so diaper changes. We might want to put mittens or socks over their hands so that they're not scratching and clawing their face. And always, always put the baby on the back to sleep. We probably were raised when we slept on our tummies, but the American Academy of Pediatrics has recommended that every baby be put on their back to sleep because of the increased risk of SIDS. Comforting is best done by mommies. And I say that with all my heart because you're the one who knows your baby. You're the one who knows your baby's cues, the symptoms of the withdrawal, and I think that mommies do it best. Breastfeeding in the past has been discouraged for mothers who were taking more than 20 milligrams of methadone, but that is no longer the case. Breast milk is the gold standard for infant feedings for any baby. Breast milk is the best. infants who are breastfed have less severe symptoms. Now, the studies show that the amount of methadone that crosses into the breast milk is very, very small. So we're not sure, according to the studies, that the breast milk actually has anything that would keep the symptoms down. But the infants who are breastfed are less likely to require medication. So go figure. Is it? I think it's the soothing. The active breastfeeding itself is what soothes the baby. They may get a little bit of methadone in it, but the studies show that they have taken the breast milk and actually studied it. The minute amounts of methadone shouldn't be what causes them to have less symptoms. I think it's the active breastfeeding, the skin to skin, the soothing. I think that's what's the key. So scoring. We use a modified Finnegan scoring system. I think soon we're going to go to something called NWI because of our charting change. But the nursing staff, once your baby is delivered, your baby will go, if everything is perfect, will go to newborn nursery for at least a couple of days until you're discharged. But we need to observe that baby for 5 to 7 days in the nursery for the symptoms, because that methadone has a half-life that's pretty long, and so it takes a while for it to get out of their system. So once it's out of their system, then the symptoms start occurring. So the nurses in newborn nursery, now I'm talking about it for Scythe, and from what I have read from most hospitals, this is pretty consistent. They'll do scoring like every 3 to 4 hours. And as long as the symptoms of the scoring is less than 8, you're good to go. If the scores go over 8 twice in a row, they're more than likely going to be calling the pediatrician and transferring to NICU or to pediatrics for treatment. So when you're discharged, after that 20, if you're a C-section, it's probably 3 days. If you're a vaginal delivery, it'll be 2 days. Your baby could come to the intensive care nursery, or hopefully, this is our new plan, to the pediatric unit for at least 5 to 7 days to continue observing for signs of NAS. Now, it's been within the last month and a half that we have been transferring babies to pediatrics, and we have a testimony of that it works. The NICU houses about an average of 50 babies per day. We have 3 parenting rooms, and we don't always have a parenting room for moms to stay. And breastfeeding is not established if you can't stay. The bonding can't happen if you can't stay. That maternal soothing can't happen if you can't stay. So we've been brainstorming of ways to keep you and your baby together. And so far, we've had pretty good success with that happening. When comfort measures are not adequate to keep the NAS scores below 8, we'll call the doctor and they'll prescribe neonatal morphine. Now, I didn't put anything about morphine on here, but we use morphine instead of methadone for the withdrawal symptoms because methadone has a really long half-life. Morphine has a really short half-life. So the weaning of morphine is easier because we give it every 3 hours, and when we're scoring every 3 hours, if the scores are low consecutively, then we can start weaning the morphine. With the methadone, it takes 24 hours for that to start coming out of the system, so it's harder to wean. So there are some facilities that use, they used to use tincture of opium and methadone. But our facility uses morphine, and we've had really good success with being able to wean. Once the scores stay below 8 consecutively, they'll start weaning the dose by 10%. If the scores during that time go back up and stay up, then we'll start going back up by 10%. So it's small increments, but the weaning has to be done slowly. If medication is needed for your baby's withdrawal symptoms, the stay will be extended. And I stress that because it's hard to not take your baby home with you in a week, but this is real. The average length of stay for a baby experiencing NAS at Forsyth Medical Center is 19.5 days. Of all the research that I did, and most of you saw my notebook, and I have lots of articles from different facilities, the average length of stay is at least 20 days, if the baby gets medicated. If the baby can go to the pediatric unit, mamas can stay there, and I tell you, that's ideal. And I'm going to give you my number at the end of this so that you can call me if you're having a baby soon, because we can make that happen. According to the National Survey of Drug Use and Health, 4.3% of pregnant women use illicit drugs. The use of illicit drugs during pregnancy almost always have unwanted side effects for the baby. Treatment of drug and alcohol-dependent pregnant women has been found to significantly reduce the rates of prematurity, low birth weight infants, and infant death. So I applaud you for getting help. I applaud you for caring about your body and your baby. So during one of our in-group sessions, we started talking about different drugs that mamas could possibly use, and Shantae said, well, why don't you include that in your presentation? So along with the neonatal abstinence, I've added a couple of slides in about different drugs that might be available or that you might have abused in the past. Marijuana and cigarettes, they have toxins in it that causes the baby to get a lack of oxygen. So it crosses the placenta and contains toxins that keep the fetus from getting enough oxygen, and so it keeps them from growing. It causes an increased risk for premature birth and possible withdrawal-like symptoms. Heroin increases the risk for serious pregnancy complications such as prematurity, premature rupture of membranes, and stillbirth. The risk for the baby is poor fetal growth and premature birth. Neonatal abstinence is very likely to be severe with prolonged heroin use. Babies exposed to heroin before birth have an increased risk for sudden infant death syndrome. This is ecstasy, methamphetamines, and other amphetamines. There's a real lack of information out there because people don't report this use. A small study found that an increase in congenital heart defects, skeletal defects like club feet, short limbs, poor fetal growth, smaller head circumference, those were part of a study that was done about 5 years ago. But there's, like I say, there's not any studies because people don't report the use. Some infants experience the jitteriness and drowsiness and breathing problems. Cocaine use during pregnancy. Cocaine does cross the placenta, and it's eliminated slower in the baby than it is the mama, so the baby holds on to that cocaine for a long time. Early use in pregnancy increases the risk for miscarriage, bleeding, and preterm labor. If you were to come in to the hospital bleeding profusely, they would more than likely do a urine drug screen to check for cocaine, because that is one of the biggest things that we see is excessive bleeding during pregnancy. So with that being said, cocaine increases the risk for bleeding, so it increases the risk for a fetal stroke, which is a bleeding into the baby's brain. Infants also have an increased chance of low birth weight, intellectual disabilities, cerebral palsy, and death. Alcohol, because Shantae said, I need to include this. This came from the Institute of Medicine, written in 1996, and it still holds true today. Of all the substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. They have sleeping, breathing, and feeding problems. They have small heads and facial irregularities. They'll have misshapen mouths. Heart defects and other organ dysfunctions are very common. There's an increased risk of deformities of the joints, limbs, and fingers, and there may be vision or hearing problems, mental retardation, delayed development, and behavioral problems. They have small heads and facial irregularities. They'll have misshapen mouths. Heart defects and other organ dysfunctions are very common. There's an increased risk of deformities of the joints, limbs, and fingers, and there may be vision or hearing problems, mental retardation, delayed development, and behavioral problems. Instead of neonatal abstinence syndrome, the effects of alcohol are called fetal alcohol spectrum disorders. They are the leading known cause of preventable mental retardation. There's an estimated 40,000 newborns affected by fetal alcohol spectrum disorder each year. The fetal alcohol spectrum disorders are more common than autism, and the effects last a lifetime. And the thing I stress about this, it is totally 100% preventable. People people ask me about the CPS referrals, the social workers. Our hospital social worker visits every baby or every mom of every baby in the NICU. So regardless of what they're in there for, our social worker visits them. If there's a history of illegal or prescribed drugs of addiction, regardless, they'll visit mamas. So don't be offended if they come to visit you, but it's just that they visit every parent of every baby in the NICU. If you have a history, there will probably be a urine drug screen done and possibly a meconium drug screen done. So if they find that either is positive for illegal drugs, not methadone, not Subutex, not Suboxone, not the drugs that you're prescribed, then if they're either positive for that, then a Child Protective Service report could be made. A CPS report is not automatically made for mothers who are taking medications that have been prescribed. And our goal is a healthy, happy baby. There are a couple of resources, and a lot of the information that I found was through the March of Dimes. There's an American Council for Drug Education and a motherrisk.org. Those are some of the resources. And I also have a little brochure that I didn't include. I included these here because I didn't put them on my brochure. I found these through a friend of mine. And then the references for the slides are here. All right?